Autosomal dominant polycystic kidney disease, important exam related topic both for your theory. In practical, you might get a case related to that in the MD for the entrances also. And those who are studying from Harrison, go through this video and you will get a clear idea. After this video, once you study Harrison, you will get good understanding of the subject, what they have given. ADPCKD, it is autosomal dominant polycystic kidney disease. Polycystic kidney disease. A normal kidney, as shown in the image, eventually turn into multiple fluid-filled cyst. Fluid-filled cyst. The kidney can reach size up to 20 centimeter. Taken. This is the typical presentation of ADPCKD. Eventually, severe disease I am saying. So what is it? It is a multi-system disease. Even though kidneys are the primary organ which is involved, the cyst can occur in any other organ. And that is why these are called as multi-system disorder. Genetic basis there, that is why it is autosomal dominant polycystic kidney disease. Multiple renal and extra-renal manifestation causes the clinical deterioration. What is the incidence? The incidence is 1 in 400 to 1 in 1000. It is a bit common in the nephrology OPD. Day in and out, you might encounter these cases. And it is one of the leading genetic cause of chronic kidney disease. Apart from diabetic, hypertension, glomerulonephritis, this is one of the leading cause of CKD. And what is the most common extra-renal manifestation? It is the liver cyst, which is the most common extra-renal manifestation. The gene which is involved is the PKD1 gene, which is located in chromosome 16, 16p. And this encodes the protein called polycystin 1. The genetic cause, these are the two gene which is involved. PKD2 is the gene, polycystin 2 is the protein which is involved. Where it is located in chromosome 4q. In the MCQ, they might ask this. Polycystin 1 is associated with severe disease, severe form of the disease, especially the truncating mutation. There are two types of mutation, truncating and non-truncating. Polycystin 1, truncating 1 is associated with severe disease. Polycystin 2 associated with minor disease. So what is the gene which is PKD1 and PKD2? A newer form of gene has been described which causes milder form of ADPCKD, which is GANAB, Ghana B gene. So mostly you have to aware of this polycystin 1 and 2. For MCQ purpose, GANA Ghana B gene is also causing mild form of this particular condition. Do all the patient and their family member will develop this because it is autosomal dominant penetrance? But the manifestation might be different because of the variable penetrance. 10% case can have without family history because of the spontaneous mutation. Do all the nephrons in the kidney is involved? The answer is no, not all. Even though kidney looks very, very big, only 5% of the nephrons are involved, 5%. And which part of the nephron is involved, whether it is proximal convoluted tubule, Lupus-Henle or distal tubule, it is the distal tubule and the collecting ducts which is involved. 4 important MCQ point. Variable penetrance 10%. Many times you might not find the family history because of this variable spontaneous mutation. 10% can occur because of the spontaneous mutation. Only 5% of the nephron is involved. Distal nephron and the collecting duct are the primary site of the cyst. Coming to the clinical manifestation. Many a time the patient might be asymptomatic. The peak can occur between 30 to 50 years if it is polycystin 1 or after 70 years. In the milder form of disease, up to 70 years, the patient might develop the symptom. They might not know also. In 30 to 50 years, if the patient is having severe genetic manifestation, if they are manifesting 30 to 50 years is the time the kidney symptom will start appearing. So most of the time it is asymptomatic. During the family screening, it might come to know, or screening ultrasound for some other reason. So suppose it have to manifest with some symptom, what it can be? It can be most commonly present with flank pain. Flank pain. The disease severity depends on the family history. At what age the parents are involved. The parents have severe probably the person might be manifesting at the same disease. Same age, same kind of trajectory might be there, one clinical clue. So flank pain, most common. Hematuria can occur in 40% of the patient. Why this hematuria? Cyst hemorrhage can happen. Blunt abdominal trauma can cause cyst hemorrhage. Cyst infection can happen. They are prone for hypertension. Recurrent UTI, because of the multiple cysts, recurrent UTI is common. The cysts have no direct connection with the drainage system, but the cysts are prone for infection. So the clinical manifestation is very simple. Flank pain, hematuria, cyst infection, and UTI, recurrent UTI. Hypertension can be the manifestation. Eventually, if the disease patient is harboring the severe genetic form, ESRD can happen in these two peak periods. ESRD can happen in 60% of the patient. There are criteria to say when the person is harboring severe disease or not. 60% probably by 50 to 60 years. The remaining 40 might go asymptomatically towards 70 years. Cyst infection most commonly by the gram-negative organism. To be particular, E. coli is more common, followed by Klebsiella. Proteus can cause renal stone. Uric acid stone is very common in the ADPCK because of the published literature. In the general population, calcium oxalate stone is common in the general population. In renal tubular acidosis, for some or other reason, phosphate is common. This we will discuss while discussing the renal stone disease. One point to notice, recurrent renal stone is also possible. The RCC incidence is not increased in ADPCKD as compared to the general population. That is one important point to note. Now coming to the ESRD. If the disease start manifesting, only 5% of the nephron is involved, it will start compressing the remaining structure. The patient develop hypertension, then the GFR might start falling rapidly. It can be as rapid as up to 5 ml per minute per year. So at this rate, patient might land in ESRD. So whenever a CKD develops, patient usually develop anemia, but in ADPCKD, anemia might not be the early manifestation because of a good amount of EPO secretion. Because ADPCKD cyst, the interstitium is maintained, whereas in other cause of CKD, the interstitial fibrosis happen, whereas in ADPCKD that is bit rare, so anemia is bit rare. Anemia do happen at the extreme end of the cases. Sometimes if the nutrition is poor, probably can occur at the early point of time. But clinically in ADPCK, anemia is bit late to manifest. Okay. Coming to before going to the ESRD, what are the predictors? Extrarenal manifestation, what are all it can be? The cyst can occur in liver. The liver cyst can grow and cause mass effects. The cyst can come in pancreas, arachnoid membrane, seminal vesicle, epididymal cyst can happen, prostatic cyst can happen, spleen cyst can be there. Why I am saying all this? The cyst in ovary is bit rare, followed by lungs is bit rare. Cyst can happen in all these organs. This is important extrarenal manifestation related to cyst. Second, CNS aneurysm, perianeurysm is common. Colonic diverticula, aortic aneurysm, mitral valve prolapse is the most common cardiac manifestation. These can happen because ciliary functions are involved. So that is why the cyst can happen in any other organ. CNS aneurysm. Okay. These are the extra renal important manifestation. As he told, the RCC incidence is as similar to a general population. It is not increased. So coming to the ESRD risk. When to say patient can land ESRD in a faster rate? When the patient symptomatically presents and the diagnosis made before the age of 30 years, patient presents with hematuria before 30 years, hypertension before at a younger age, 35 years, dyslipidemia, and in the genetic analysis if there is a PKD1 truncating mutation. PKD1, some people might be having doubts about what is this truncating. Depends on the patient gene. There are two types of mutation, truncating and non-truncating. In detail, you might not require both for clinical practice and for your entrance exam. Just remember, truncating, if the word comes, there's a poor prognosis. Okay, poor prognosis, and there are two type of mutation, truncating and non-truncating. So if it is there, there's a chances patient is harboring a severe disease, they will land in ESRD at an earlier stage. One another clinical point, the cyst volume is the strongest predictor of the renal function decline. Higher the cyst volume we check with the help of MRI, that is called as total kidney volume. In that we will be knowing individual cyst size and all. Higher the cyst size, higher chances of renal function decline. This is one clinically important point. To understand the treatment, this pathway in polycystic kidney disease is very important. So many letters, so many words. A student might get confused. Let us simplify it. Let us simplify here. What are these polycystin? PKD1 gene and PKD2 gene are making two protein, polycystin 1 and 2. These are present in the cilia and they are important for cell to cell contact, cell matrix contact, and it acts as a transmembrane channel also, transmembrane signaling. Inside the cell, if the calcium is there, cell proliferation will be under control. The secretion of chloride will be under control inside if the cell is inside the intracellular environment. Polycystin 1 and polycystin 2 help to maintain this. Suppose if there is a problem in these two, calcium, intracellular calcium goes low, so cellular proliferation will activated, chloride secretion will get activated. So there is cell proliferation and chloride secretion. So cyst contain chloride rich fluid. This is in simple terms. Once again, intracellularly calcium is low, which is leading to the cellular proliferation. During that path, there are so many signaling pathways. What are those? See, here is the polycystin PC1. Here is the PC1. Polycystin 1. Here is the polycystin 2. Here is the calcium. Basically, what is happening because of some issue, because of the mutation, calcium is going low. So this cyclic AMP is not being able to destroy it. This is phosphodiesterase, somatostatin receptor. Just I am telling the expansion of this particular adenyl cyclase, arginine vasopressin. This is V2 receptor. V2 receptor. There are receptor which are tied to cyclic AMP. If cyclic AMP is very active, what will happen? It activates the protein kinase. Protein kinase is sitting in the center. Once it is activated, chloride secretion can happen through cystic fibrosis transmembrane receptor. Other side, cell proliferation can happen. Between these, there are mTOR pathway, MAPK kinase, mitogen associated protein kinase, mammalian target of rapamycin. These are some signaling pathways which lead it to cell proliferation. So what is the overall thing? Calcium is low, so cyclic AMP is overactivated. Whenever vasopressin is activated, cyclic AMP is getting activated. Whenever somatostatin is not there, this will get activated. So protein kinase A is activated, so it is secreting the fluid and causing cell proliferation. So treatment, what we have to do? We have to stop all the things which are, either we have to increase the calcium or we have to stop the cyclic AMP. Cyclic AMP is activated by vasopressin and it is activated because somatostatin is not there, or we have to stop the protein kinase or downstream pathway. Any of the downstream pathway we have to block. So this is the important signaling pathway in polycystic kidney disease. This is the important pathophysiology also. Simple, low calcium intracellular leading to activation of protein kinase A. That's all. Okay, don't get confused. So many letters. See, yeah, cystic fibrosis transmembrane receptor is involved. Okay, that's all. Simple. Now coming to the investigation. Basic blood investigation like complete blood count, KFT, LFT we have to check. Ultrasound will show the kidney cyst, CT, MRI, and genetic testing. These are very particular. In the MRI, what one parameter will be saying in the total kidney volume. Total kidney volume. It can come as 600, like total kidney volume. Higher the volume, poorer is the prognosis. So this is one MCQ related. In the ultrasound, what are the, how many cysts should be there to diagnose as per the age? There is the Revine's criteria. Below 30 years, more than 2 cysts, either in one kidney or 2 kidney, will make the patient towards ADPCKD, look at the positive predictive value. And up to 60 years, only more than 2 cysts in each kidney is required. After 60 years, more than 4 cysts is required. Why? As the age increases, the criteria of number of cysts increases. Because in old age, simple cyst is possible, common, simple cyst is common. So that is why the age criteria is changing. This you can remember for MCQ purpose. So how to tell the prognosis? As I told, genetically we can tell whether truncating or non-truncating mutation. There is one scoring system called Pro-PKD score being used, and imaging. As I told, in the imaging, if the size is more than 16.5 centimeter, in the simple ultrasound, in the ultrasound only, if the size is more than 16.5 centimeter, the prognosis is poor, and for total kidney volume, we need the MRI. So just remember, Pro-PKD score is used in ADPCKD. What they use? They use the clinical criteria and genetic criteria. Clinical 4 parameter they take the age, hypertension, onset, renal disease, like that. In detail, probably might not be required. Just remember, this is how we assess the prognosis. Now coming to the treatment option, how we can treat this condition. As we know, in the beginning we have seen, it is not about only the cyst treatment, it is about managing the ESRD, managing the UTI, managing the cyst hemorrhage, managing the overall condition. With respect to the kidney itself, first is BP control, high water intake, especially in this situation, AC inhibitor ARB for renal disease progression stoppage, how to manage UTI, role of tolvaptan, newer drug, transplant, and other dialysis related stuff. These are all the treatment option we are having related to ADPCKD. With respect to BP, a lower BP, less chance of progression. BP target of 130 over 80 in ideal situation. There is one trial they have did which is called HALT PKD trial, where they have targeted the lower BP 110 over 80 in an individual patient. They have showed a lower systolic BP reduced the progression. Lower BP reduced the progression. The HALT PKD trial. In some situation, if we take the BP lower than 110, then it can cause, probably the outcome might not be that much good. So based on HALT PKD trial, the BP target can be 110 over 80. In Harrison, sometime you get this sentence, lower BP, but once the HALT PKD trial is done, I have showed 110 over 80 can be the target, which shows better preservation of the renal function. The progression is less. So what is the ideal target? Ideal is 130 over 80. In certain situation, in severe form of ADPCKD, BP over 110 over 80 is fine, or is the target. On condition is that patient is not developing side effects of the antihypertensive drug. So this is the first one. Coming to the second one, as the water intake is increased, serum osmolarity goes down. So the secretion of AVP, antidiuretic hormone, goes down, so that the receptor activation goes down. That is the concept behind. And also increasing the hydration prevents the recurrent infection. The patient's outflow tract will be better diluted. The chances of renal stone disease formation is less. The urine output have to be targeted. A patient taking 2.5 liter or 3 liter plus, 4 liter plus, and going for a running, losing everything to sweat, it might not help. The urine output have to be targeted towards more than 4 liter. Because of this particular reason, the urine osmolarity have to be brought down more than 4 liter. Recurrent UTI, how to manage? We have to select lipid-soluble antibiotic like cotrimoxazole, quinolone, or foramplicol. The cysts are not in active contact with the glomerular filtrate because these are chloride-filled cysts, not in contact with the filtrate. So we have to give drugs which will penetrate the cyst and go. So select any of these drugs. Even phenum group can be selected. Now coming to the V2 receptor antagonist, tolvaptan, V2 receptor antagonist. That is why I told that pathophysiology slide is important, because V2 receptor activation causes more cyclic AMP. More cyclic AMP causes cell proliferation and chloride secretion. So we can start at 15 milligram and it can be increased up to 45 milligram. It have to be given for 3 to 5 years. It can't be given for 15 days and you can stop. It have to be given for a long period of time. In the runway, in the patient lifespan runway, it have to be started at the earliest. That is why we have to check the poor prognostic marker. If there are poor prognostic marker, 12 after have to be started earliest. Better to be started when the eGFR is above 30. If eGFR started going below 30, at that time if we start 12 after, it might not be helpful. Liver function test to be monitored whenever we start 12 after, because it is hepatotoxic and it might cause sodium related issues in the patient. So sodium have to be monitored once 12 after is started. Now coming to the somatostatin analog, all the treatment is based on that particular flowchart diagram we have seen. Based on that one only. Somatostatin receptor is inactive, so we have to give analog like octreotide, lenalidomide, pasireotide. These are being used in the treatment of ADPCKD. Clear guidelines are yet to come, but in the MCQ they might ask you. In the medicine 4th paper they might ask you what are these. A statin group, HMG-CoA reductase inhibitor, being used in particular trial and has shown some proven benefit in a small RCT. Bosutinib, it is a, as we saw in the protein kinase A, below which there is a pathway. In that mTOR was there, SRC was there, all which lead to cell proliferation. Protein kinase A, mTOR, SRC, MPAK. This all led to activation of the cell proliferation. So blocking this, which causes inhibition of the cell growth. So it's a bosutinib is a kinase inhibitor, which is being also tried. Further drugs, just name you have to remember is multikinase inhibitor, metformin also being used, pioglitazone is also being used, nicotinamide, triptolite. These are the drugs under the clinical trials, all based on that particular image I have shown, the cell proliferation and the initial activation of cyclic AMP, or here tyrosine kinase was there. Any of the thing we are trying to block. Once it is blocked, the ADPCKD cystic growth might not be there or it can be halted. These are under research. Probably within a decade, one drug should give hope to 2 million of people. Let's see. And with respect to transplant, the transplant outcome, the kidney transplant outcome is same as in general population. There is no worse outcome. And whether to remove the kidney or not, many a medicine PG, even a third year medicine PG once asked, sir, in the kidney transplant, they will remove the native kidney and keep the new one. Normally, for transplant, the native kidney will be kept inside only. The third kidney will come to the right iliac fossa or left iliac fossa, preferably the right iliac fossa. After transplant, patient will be having 3 kidneys. Okay, this is for general. In ADPCKD, the cyst will be very, very big, whether to remove it or not. Unless patient is developing infected cyst, frequent infection, mass effect, then we might not remove the kidney. If there is a mass effect, recurrent infection, if the patient is developing recurrent infection, nephrotoxic antibiotic have to be given and patient might not tolerate that. So that is an indication for nephrectomy and keeping the new kidney. Otherwise, you can keep the new kidney as it is, similar to the general population. The outcome is as good as the general other causes of CKD only. There is no specific change in the outcome. And what about the other RRT? Hemodialysis is preferred rather than the peritoneal dialysis if the patient is landing in ESRD. And why PD is not? Because the risk of infection is high. Fistula is the preferred one as the vascular access. IJV or permacath. Similar to a general population, there is no specific guideline similar to ADPCKD. So this is all about ADPCKD. With this background, go and study Harrison. And one more last slide. Some trials related to ADPCKD. What are these trials? Let's remove this one. So these are all the trials. CRISP 1 trial, CRISP 2 trial, Mayo school data, Mayo clinical class. What is this? This is based on the MRI. We will check the total kidney volume and we will plot the patient into 3 categories. Higher the category versus the prognosis, we have to start the treatment first. HALT PKD, what they have checked? They have checked the low BP and the progression. In TAME PKD, what they have checked? Tolvaptan, they have TAME PKD. In TEMPO 3:4 repress, they tried tolvaptan. And in CRISP 1 and 2, they checked the progression. So for a medicine resident, just remember these are the names of trial related to the ADPCKD. You might get in your difficult question in NEET. Out of 200 questions, 160 anyone can answer. Sorry, 60 anyone can answer. 100 those who studied can answer. 40 very very difficult. It will come under the difficult category. This is the names. For your theory, up to here is enough. So this is the image this we took from our ward. The patient had a very big sized kidney. The entire abdomen is replaced with the kidney cyst, liver cyst also you can see. So in ADPCKD, what we have seen, what is it, clinical feature, pathophysiology, investigations and management. I hope you understood. Any doubt, comment below. We will see in the next video. Bye bye.